I must say, as a pathologist, I don't get to interact with patients particularly frequently these days, and to hear Julie's moving, raw story, it fills me with passion that we need to work harder to deliver on our goal of 0 deaths from melanoma. And in fact, that's what our goal is here at Melanoma Institute Australia. And I think it's only by partnering with patients as well as researchers and doctors that will deliver on this goal. We've got 3 pillars of activity here at MIA: the clinical care of melanoma patients, education of health professionals, and research. And all of those things are what's going to deliver on our goal of 0 deaths from melanoma. But the patient remains at the centre of everything that we do. We've got 3 groups of experts who work on delivering on each of these 3 areas, but the patient remains at the centre. And in fact, we have patient and consumer representatives on our education and research committee. So thank you to Michael Armstrong, who's in the audience, and Craig Lawn, who couldn't be here tonight. One of the most important activities we have at MIA is our multidisciplinary team meeting that happens every Friday morning at 7 o'clock, where we discuss our most challenging clinical problems and try and work out together what we'd recommend as the best way that we think those patients should be managed. And it's through these discussions that often raises the most important research questions that we're tackling today. We're very fortunate in Australia that our patients have been very generous in providing us with information about them, providing us with biospecimens, their keenness to enrol in clinical trials. And it's because of those activities we're able to perform research. And this research, these patients who are generously giving us this material, they themselves may not benefit from it, but they're seeing the benefit that is likely to come or may come to patients down the track. To deliver on our goal of 0 deaths from melanoma, we've designed our research strategy to follow the patient journey. So we've divided it into 5 themes. The first theme is around prevention, because obviously prevention is better than cure. Our second theme is around early stage melanoma. Our third theme around advanced melanoma. Another theme that both Victoria and Julie have highlighted is about supportive care and survivorship. And as we've already heard, this is becoming an increasing issue in melanoma, as patients who previously may not have survived are now surviving for longer periods. So in fact, we're working hard to bolster this theme, and we're excited to tell you about the head of research psychology that we appointed earlier this year, Dr. Iris Batula, who's developed a fabulous strategy for this theme. So we'll be doing more work in this space as we move forward, and partnering with Melanoma Patients Australia to do that. And our last theme is around health economics, because we want to prove that what we're doing is cost effective for the Australian community. All right, so as Matthew said, I'm a pathologist, so I work from behind the scenes. I'm one of many people who work hard behind the scenes, but as patients, I want to tell you, there's this team of people who've got your back, who are looking out for your best interests that you don't ordinarily get to meet, except on nights like tonight. These are the 4 things that I want to cover in my talk. So first of all, what is melanoma? Talk a little bit about diagnosis and prognosis. Mention sentinel lymph node biopsy. And lastly, I want to finish on the very exciting area of personalised medicine, which we're really leading the cancer field in melanoma. So first of all, what is melanoma? So this is a schema of the skin. The top part of your skin is called the epidermis. So this is like the waterproof layer on the outside of your skin. And in normal skin, there are these pigmented cells called melanocytes that sit on the basal part of the epidermis, and their job is to produce pigment that they send out to the surrounding cells. And basically, the main function of this pigment is to absorb ultraviolet light from the sun when it passes through the skin, and to prevent the harmful effects that it has. So it has a job to do. When these these cells, melanocytes, when they start growing uncontrollably and they won't stop growing, that's what a melanoma is. So it's a tumour of these cells called melanocytes, pigment-producing cells of the skin. Okay, moving on to diagnosis and prognosis. So I know many of the people in the room are people who've had melanoma, so there's different ways patients may present, but the commonest way is presenting where they notice something on their skin that's changed, and they'll usually go and see their doctor and ask them about it. The doctor will examine it more carefully, and if they're concerned that it might be a melanoma, they'll perform a biopsy, and that biopsy is sent to the pathology laboratory where a team of people look at this sample very carefully, select bits of it out to make very thin tissue sections that we can examine down the microscope and find out more about the tumour. So what we're trying to do is look at this bit of tissue and tell what's going to happen in the future. So a bit like a fortune teller. There's two things that we're trying to figure out when we look at a sample down the microscope. The first of all is it melanoma or is it something else? And the second thing is, if it is a melanoma, how bad is it? Because this is important for the next stages of melanoma patients' management. So the first thing we're trying to do is separate out the good guys from the bad guys, so the melanoma from the nevi. And, you know, to become a pathologist takes about 15 years of training. So we do medical school training and then another 5 years of specialist training in pathology. So for most cases, they're usually straightforward. We can make the diagnosis accurately, quickly and reproducibly. But there are cases where it is more challenging to make a diagnosis. In fact, there's some cases that are melanoma, but they look like a benign mole, like a nevus. So wolves masquerading as sheep. And on the other side of the coin, there's tumours that look like a melanoma, but they're actually a nevus. So sheep masquerading as wolves. So we need to be able to recognise those and to try and make the diagnosis. All right, so once we've made the diagnosis of melanoma, the next important question is what's likely to happen in the future? So is it likely to cause troubles or not? And this is important because the recommendations that are given to you as a patient regarding your follow-up and the next stages of your treatment are principally based around the things that I see down the microscope. So types of treatment, the width of excision margins, whether it's recommended you have a sentinel node biopsy or even drug therapy for some patients. The most important feature that we look at down the microscope that tells us how bad the melanoma is the thickness, so this vertical depth. So it's not how wide the melanoma is, how big it looks on the skin surface, it's how far it's invaded down into the deeper part of the skin, because that's where it gets access to blood vessels and what we call lymph channels, where the melanoma can potentially get access to travelling elsewhere. We divide melanoma into 4 different categories based on how thick it is, and that correlates with its risk. And there's many other features that we also look at that you'll see when you get your pathology report, which also influence prognosis and treatment. But the number one factor is the thickness of the tumour. The next feature I want to mention is sentinel lymph node biopsy. So what a sentinel lymph node is. So when a melanoma is present on the skin surface, it can spread elsewhere. And the first spot that it usually spreads to when it's going to spread, not always, but usually, is the sentinel lymph node. So this is the first lymph node that drains from where the initial melanoma was. So nuclear medicine physicians can identify where this one particular node is by using radio tracers and other techniques. And your surgeon will then come along and identify that node, cut it out, and it'll be sent to me to look at down the microscope. So we cut lots of sections and look at it very carefully. And this is very important because if this sentinel node has tumour in it, that changes things, and it might change the recommendations that your clinician makes to you about how your melanoma should be managed. So first of all, it's the most accurate prognostic test that we currently have available for patients who've got primary melanoma. And it also identifies patients who's, when their melanoma spread, they may benefit from using drug therapies that Georgina provides, so reduce the risk of the disease coming back. So we call that adjuvant drug therapy. All right, and the last thing I want to very briefly mention is this exciting area of personalised medicine. So the idea of this is we're trying to get the best treatment for individual patients and give it to them at the right time to give them the best chance of cure, not give treatment to patients where the therapy's not that likely to work, when it may be associated with side effects. And this will save patients time, get them on the best therapy earlier, save costs and save side effects. When we've thought about cancers in general, in the old days, until fairly recently, we really only looked at the tumour itself, what it looked like down the microscope, and more recently the DNA of the tumour. But we now know that there's many other factors that are also very important in controlling your response to treatments and what's going to happen. One of which is the microenvironment in which the tumour sits, very important. Also host factors, so related to the patient's immunity, but also other host factors are important in determining outcomes. Even environmental factors, including diet, are important. And as Georgina and I are both going to briefly mention in our talks, we even know that the microbiome, so what's in your gut, affects your response to different treatments. So this is a slide I borrowed from Georgina. We've now got these two superheroes in our fight against advanced melanoma, targeted therapy and immunotherapy. And I'll highlight these for, Georgina will tell you more about these in her talk, but I just want to highlight the fact in targeted therapies, we've got this great biomarker to identify which patients will likely to respond to this therapy. It's called the presence of a BRAF mutation, and we've got various ways of testing for that, but we can identify people very carefully by doing this. But unfortunately, in immunotherapy, we're not so good at, we don't have such great biomarkers to work out which patients will respond and those who won't respond like we do in targeted therapy. So this is an important unmet need that we're working very hard on to address. In fact, our personalised immunotherapy project is the project which Melanoma March funds are supporting to deliver on. So what we're trying to do is we've got groups of patients who have been treated with immunotherapy. We get a biopsy of their tumour before they've started therapy. They're treated with different therapies and and then over time, some of them respond well, some of them don't respond well. We can analyse their tumour and try and find signatures which tell us which patients will respond and which ones won't. Then when we get a new lot of patients, we can apply that signature to divide the patients into those with a good signature and a poor signature. If they've got the good signature, then we can give those patients the type of therapy that they're likely to respond to. But if they have that poor signature, we've got to analyse their tumours much more carefully to figure out what therapy is going to be best for them. So that's what our personalised immunotherapy. And we also, as I mentioned, the microbiome is also important in modifying that, and we're doing some work on that. The last thing I wanted to mention, the other exciting area that we've been working on is an area called circulating tumour DNA. So with a blood test, we can look at tumour DNA that's circulating in your body. And so when we're monitoring patients who have been treated with immunotherapy, a traditional way of monitoring it is with radiology. Here's one of Georgina's patients that had a tumour in the inside of their lung, and the patient was commenced on immunotherapy, and it looked like it was getting bigger at 12 weeks. And so at this stage, Georgina might be saying, oh, should I keep going with the therapy or swap to something else, because the radiology is concerning. But luckily, Georgina kept going with the immunotherapy and the tumour shrank down with time. But when we've looked at circulating free tumour DNA, this drops very quickly when patients are responding, much more quickly than what we'll see on radiology. So this is a very useful tool for us in monitoring patients. So that's all I wanted to say about personalised, our personalised immunotherapy project. That's what I've covered today. I'd like to thank various people that I work with, but I also wanted to say, on behalf of Georgina and myself, how excited we are, first of all, to be hosting you here tonight, but also this fabulous pioneering partnership between MPA and MIA. It really brings us to a new era, and it will certainly assist us in helping patients and delivering on our goal of 0 deaths from melanoma. Thank you very much.